Well, hello everybody, and welcome to our Pediatric Asthma webinar series. Today is the third webinar of the series. I'm Lana. I'm a curriculum developer for the Provider Education Program and of the Lung Health Foundation. And I'm also a respiratory therapist and certified respiratory educator. So, as I mentioned before, our pediatric asthma webinar series was created to end the gaps and assess the diagnosis, risk factors, and appropriate management of asthma in our pediatric population. Today's webinar is going to be called When Objective Measures Are Not Available, and will focus on diagnosing asthma in our preschooler. So we have a wonderful speaker today, Dr. Ryan Smith, who's going to present it for us. And just before I introduce Dr. Smith, I just wanted to tell you that, again, we're going to have approximately 45-minute presentation, and then we will have some questions and answers. Dr. Smith will answer your questions, and this time, he will also be asking you some questions. So this is going to be a nice interactive session, and I'm looking forward to hearing that. Now, it's my pleasure to introduce Dr. Smith to you. So Dr. Ryan Smith is a consultant pediatrician in Aurelia, and he is also a staff pediatrician at Aurelia Soldiers Memorial Hospital. He has a strong interest in pediatric asthma. Dr. Smith serves as a senior associate editor for the Journal of the Canadian Pediatric Society called Pediatrics and Child Health. Dr. Smith is an ongoing consultant for 2 provincial committees on asthma, and currently he is also a medical director for the Regional Pediatric Asthma Clinic at Aurelia Soldiers Memorial Hospital. Welcome, Dr. Smith.
Thanks very much, Lana. Hi, everyone. Thanks for joining us today. As mentioned, the topic will be around diagnosing preschool asthma. And thanks for the introduction. I am a consulting pediatrician, but I have a special interest in asthma, and that's what brought me here today. So those are the learning objectives. I have no financial relationships. We put this talk together with a focus on mitigating any potential bias in the slides or the material that's being presented to you today. It is eligible for CFPC main pro credits, your family doctor. And there are some references available. So I think we should start with a definition. Asthma is defined as an inflammatory disorder of the airways with episodic or persistent symptoms. And there's variable in airflow limitation. And there's airway hyperresponsiveness to endogenous or exogenous stimuli. So this is the diagnosis, or this is the definition that we use. And it also is applied to children. There's narrowing of the airway in asthma, which leads to thickening of basement membranes and mucosal edema. There's also bronchial smooth muscle contraction and hypertrophy. And you get mucus plugging from mucus secretions, plus or minus epithelial damage. In children's airways, and even smaller children like preschool children, you'd expect even smaller airways and more degree of obstruction than you would see in adults. This graph simply displays the prevalence of asthma, and you can see that top line is looking at the 0 to 4 year age group, which is by far the most highest incidence of asthma in Ontario. This graph stems from a study which surveyed caregivers and patients, and they were asked if they were ever diagnosed by a physician with asthma. And you can see again that the prevalence rates are greatest in the younger age groups, with males being higher than females. And of note, that relationship actually flips in the adolescent years. So in our asthma clinic, we tend to see more females who are teenagers. Not only are they the most prevalent age group in preschool, they're also the age group that presents the emergency department attention the most for asthma-related symptoms. And that's shown in this graph. There's a slight predominance of male over female in the younger age group, but again, much more predominant overall. So I thought I'd do some cases throughout, and as we go through these, I may ask some questions which you can either answer in line or in your head. I'll talk about Joanne, who is a typical case, a 3-year-old female with cough. She had quote unquote wheezing at home for 2 days, described by the mother. On our consult, we looked in the ED note, and the emerge physician stated there was a bark-like cough at the bedside. There's no fever. Heart rate is 130, respiratory rate 30, saturation is 92% on room air. There's no work or breathing noted. There was documented scattered crackles and no rash, and the abdomen was benign. So this is a stock photo of an x-ray, but I think it's quite typical of what you might see. The emerge doc elected to obtain the x-ray, looking for any underlying causes. They did nasal swabs, which are negative, and they labeled the child as having reactive airways disease. They treated with salbutamol, but they also treated with amoxicillin, thinking that there was some consolidation in the right middle zone there, and dexamethasone. So I'd like you to think about this case. I think it's quite typical for cases we're consulted on, and think if you would do anything differently. And so when I took the history, I found out that there were 2 previous presentations for the same in a similar manner. There's cough with activity while at home. And in the ED, the crackles, or so-called crackles or sounds that the physician was hearing, improved with salbutamol administration. So this is the essence of the talk today. Can we make a diagnosis based on that information? And how would you proceed at that stage with this child? So the recommendations come from the Canadian Respiratory Guidelines of Asthma in Preschoolers that were published in 2015, and that's what I've drawn on for this presentation. I'll go over them in detail. That's what the article looks like there. And there is an importance in diagnosing asthma early. Of note, most children with asthma have onset of symptoms in the preschool years, as we mentioned in those graphs. The diagnosis should be considered in children aged 1 to 5 with recurrent asthma-like symptoms or exacerbations, even if they're triggered by viral infections. And wheezing in early life can be associated with a reduction in their FEV1 at 6 years of age that frequently persists into adulthood. Early diagnosis is important. We want to get these kids early, avoid treatment delay, because we reduce morbidity, and there has been some studies looking at remodeling, which can persist into adulthood if things aren't detected early. So I have a question for the group. In preschoolers who cannot perform routine spirometry, what criteria should be used to diagnose asthma? Is it A, documented clinical evidence of airflow obstruction, B, no clinical evidence of an alternative diagnosis, C, documented clinical evidence of reversibility of airflow obstruction, or D, all of the above? And now when I'm usually doing an in-person presentation, I ask for a show of hands. I'll ask you just to note your answer in your head. And for those of you who guessed D, you're correct. It's all of the above, and we'll go through those in detail. First, though, I'd like to mention previous diagnostic approaches in children. Those consisted of prediction of persistent symptoms, such as the Asthma Predictive Index, which was based on family or personal history of ATP, or the age at onset of and trajectory of symptoms, for example, transient wheezers versus persistent wheezers. Then children were often diagnosed based on their symptom triggers, so-called episodic viral wheeze versus multi-trigger wheeze, which is perhaps important for fine-tuning, but it shouldn't be the basis for diagnosis. There's limitations in all of these methods. The prediction rules are imperfect. We definitely need to differentiate between phenotype and diagnosis. Children can move between groups over time, so they're not perfect placeholders, and they don't predict the response to asthma treatments or take into account the severity and frequency of symptoms. This information on the limitations comes straight out of the Canadian Pediatric Society position paper and the 2015 guidelines. I'd like to highlight the diagnostic criteria, and this is the meat of the presentation. If you have recurrent asthma-like symptoms or exacerbations with airflow obstruction and reversibility, you should consider asthma while ruling out any alternative diagnosis. Of note, personal HPs such as eczema and food allergy are important, as is family history. It should heighten your suspicion, but it's not necessarily for a diagnosis now. So this is a bit of a busy slide, but this is how it's presented in the document, and I'll try to pick out the key parts of it. You do need 1, 2, and 3. From 1, the preferred method is a documented wheeze or other signs of airflow obstruction by a physician or trained healthcare practitioner. Alternatively, you can get a convincing parent report. 2 is documentation of reversibility, and that's when you give them salbutamol, or oral corticosteroids by a physician, or the alternatives are a convincing parental report. And 3, you want to make sure there's no evidence of an alternative diagnosis. And I'll go over some hints and tricks of things to think about in that context. Airflow obstruction is most thought of as wheezing. That's the most specific sign. But honestly, in our practice here, we often ask about cough. Cough is a less specific but more frequent sign in these children. Coughing with activity or emotion, coughing at night, or worsening and prolonged cough with colds. You can also think about tachypnea, prolonged expiratory phase, accessory muscle use, decreased breath sounds, or hypoxemia would be late presentations. Reversibility talks about clear and timely response to asthma therapy. And if they have objective signs of airflow obstruction, you would give them salbutamol. This is what we routinely do in the emergency department. And if they're more of a moderate presentation, you would also give oral corticosteroids at the same time. If they present with no objective signs of airflow obstruction, that is no wheezing or cough at the time, you look for convincing parental report of symptomatic response to a 3-month trial of ICS and as needed salbutamol, or repeated observed response to salbutamol alone. Either of those methods is needed. Then we talk about no alternative diagnosis. So through the medical history and physical exam, we rule out other possibilities. Of note, they mention additional investigations are not required to diagnose asthma in this context. And this is important for parents because they often ask for the test. Well, how can we diagnose asthma without the test for asthma? And they're talking mostly about spirometry in this context. And so the key of this guideline is that you don't need an objective measure such as spirometry. It's part of the picture when they're older, and we should obtain it eventually, but it's not needed to make the diagnosis. Chest X-ray may be indicated in specific instances to rule out other causes of wheezing or comorbidities. So if we go back to Joanne, 3 years old with cough, they did a chest X-ray and emerge. It's possible when you hear scattered crackles that you should be thinking about that. However, to really make a diagnosis of pneumonia in this age group, you typically have fever. If it's a rip-roaring bacterial pneumonia, that's usually what I'm looking for. And of note, in bronchiolitis and in asthma, you can see some middle lobe changes. And I don't quite see a full area of consolidation with bronchosystole markings present on this. And often that's what we see, is that it's an overcall. And if we think back to her history, she responded to salbutamol, and pneumonia typically or does not respond to salbutamol. Now, I suppose could she have both? But I'd like to challenge you to think about the probabilities of that. And we're seeing more and more of that, where they're treated with all possible outcomes. But really, this highlights the importance of diagnosing asthma in this age group, in that they are treated down the asthma pathway, and they are not getting unnecessary investigations, and they're not getting treatments that they don't necessarily need. I'll just highlight some of the alternative diagnoses. Bronchiolitis usually presents in infants less than 12 months of age. In some of the clinical trials, that's the strict definition. They definitely have airflow obstruction. They present with coughing, but typically, not all cases, but a lot of cases will not have response to salbutamol. So that's one key distinguishing feature. If they're having repeated wheezing episodes under 12 months of age, you may think about asthma at that time. So looking at red flags or signs and symptoms suggestive of an alternative diagnosis, think about a patient that presents with stridor or noisy breathing, particularly in the under 12-month age group. You might be thinking about laryngomalacia, more rare but possible tracheal stenosis or a vascular ring or tumor. If it's an acute onset or there's a history of choking, think about foreign body. Cystic fibrosis has other signs or symptoms, including poor weight gain or failure to thrive, steatorrhea, clubbing, and you should look for nasal polyps. Bronchopulmonary dysplasia, you've got to ask about the birth history and prematurity. If they have wheezing due to cardiac failure, they may have a murmur or known congenital heart disease. And then there's rare, weird, and wonderful things like primary ciliary dyskinesia and immune dysfunction, which I posted there. This is the algorithm that's presented in the paper, and I'll try to simplify it in the talk today, and we'll take it apart piece by piece. So and of note, this is for the preschool group only, age 1 to 5. So if they present to you with airflow obstruction, so coughing or wheezing, that would be the patient in your emergency department typically, but could be in your office. And there's no red flags for an alternative diagnosis. Then we'd think about a therapeutic trial. So if it's a mild exacerbation, you can do salbutamol alone. If they're more moderate or severe, then you think about salbutamol and oral corticosteroid. Then we have to see if there's improvement. If there is clear improvement, then we think about suspected asthma. If it's happened 2 or more times, then we give them a diagnosis at that stage. If there's no or unclear improvement, then we're not sure about the diagnosis. You can elect to have a period of watchful observation, or you could think about a referral to a pediatric asthma specialist. Therapeutic trial with obstructive signs at the time in this age group would be salbutamol, and we typically give them 4 puffs or more as a first dose. Of note, I think at Sick Kids, our last time I checked, they were giving 8 puffs. The document talks about 4 puffs in the emergency department. And the most important part of this slide is reassessment. So you want to see if that cough or that wheeze is going away with salbutamol, because that's a key diagnostic criteria. If it's a moderate, sorry, the slides are advancing on their own. If it's a moderate or severe exacerbation, then we're going to think about giving the oral corticosteroid as well. How about if they present with no current signs of airflow obstruction? So this would be more of a patient who's presenting to your office or outpatient setting with a history of reported episodes that sound like asthma. Well, you have to ask if they have no previous documentation of signs of reversibility or obstructive signs, and no red flags of alternative diagnosis. So then you can either do a therapeutic trial if they have frequent symptoms, that's more than one. And that would be a medium dose of inhaled corticosteroid, and we'll go over what dose that is, with as needed salbutamol, and you reassess at 6 weeks and 3 months. If they haven't had more than one symptom, then we monitor and reassess. But you could also consider a therapeutic trial of salbutamol as well. And typically that's what I would do. I give them the salbutamol inhaler, I teach them about how to use it, and I reassess after a short period of time to see if, in fact, there was reversibility. So in this case, salbutamol as an outpatient would be 2 puffs every 4 to 6 hours, and most of you are aware of that. And the daily inhaled steroids in a moderate or severe exacerbation group would be beclomethasone dipropionate, which is QVAR, 100 micrograms BID, ciclestimide, which is Alvesco, once daily, 200 micrograms, or fluticasone propionate, which we know is Flovent, 100 to 125 micrograms BID. This presentation is recorded, so you can always go back and look at those tables in detail. It's very important to see if they have a response to therapy. You can't just put them on the medication and see them in 6 months. Preferably, the therapeutic trial will be conducted during the season when the child is most symptomatic. And a conclusive therapeutic trial requires review that they're adhering to the asthma medication, that they have adequate inhalation technique, and that there's clearly documented signs and symptoms, and that you've reassessed them in a timely manner. And again, follow up at 6 weeks and 3 months is suggested by the guidelines. I have another case that I wanted to go over, and this is a real case I saw in my office recently, so I thought I'd put it into the talk. It's a 4-year-old girl with referred to me with recurrent pneumonias. Usually when I see that, I think about asthma, in fact, because they can often present with right middle lobe consolidation, and you get a story of prolonged cough, and occasionally wheeze, but we'll go through it. So her typical presentation was actually fever, consolidation on chest x-ray. She'd be treated with amoxicillin with improvement in symptoms. I pulled up all her chest x-rays in the clinic, and I wasn't too sure. So some of them had linear atelectasis with middle lobe changes and so-called round pneumonia. The primary care physician did a repeat x-ray when she was well, and that change resolved, which is a good thought, because you could have a vascular malformation or something else in the lung. You want to make sure it's not there on repeat. And she was typically treated with ICS and salbutamol as well. So just to round out the history, she was born on time. There's no issues with pregnancy, labor, delivery. She had been growing and gaining weight. There's no regular medications otherwise. There's no family history of asthma or HP. Development was typical for her age, and review assistance was negative. So what are we missing here? So I delved into the history a little bit more, and it sounds like she was coughing and choking with thin liquids for some time. And we did an examination and looked in her mouth. The tonsils were grade 2. Thinking about CF, her hands were normal. There's no nasal polyps. She had normal cardiorespiratory and abdominal examination in the office. And in fact, with that story of choking, we proceeded with a feeding study, which actually showed laryngeal penetration of thin liquids, and she was referred to OT for strategies with pacing. And so this was a girl who didn't have asthma, but was always treated with ICS and salbutamol. And I think a key piece of this story, and highlights sort of the guidelines, is that if you're not having reversibility, it's unlikely, it doesn't meet criteria for asthma. It's unlikely to be asthma. So really, she shouldn't have been treated with the ICS and salbutamol. So it highlights the importance of thinking of alternative diagnoses when you're going through the pathway. All right, we're just going to pause and do another polling question to break things up. What factors may predict that a child will continue to have asthma symptoms into adulthood? Is it A, asthma symptoms are only triggered by viruses? The child has allergies. The grandfather has COPD. the first episode of wheeze occurred before the age of 2 years, or pet dog or cat in the house. I'll just check my time. Looks like we're doing pretty well. For those of you who said B, you would be correct. Allergies are predictive of continuation of symptoms. And this is an older study, but it's actually more of a landmark trial. And I remember learning about it in my residency training. There are different phenotypes of asthma that should be kept in mind. And so-called transient early wheezers tend to outgrow symptoms by around 3 years of age. Then you have the non-atopic wheezers, so they don't have allergy or eczema, and they peak around the 3 to 6 year age group, but then grow out. And then you have the IgE-associated wheeze and asthma, those are the ones who are atopic, and they tend to persist into early adolescence and sometimes adult. And so what predicts preschool versus persistent? These are, it's a great study by Dr. Covesi, but it's not definitive by any means, but these are the trends that he found. Transient viral-induced asthma starts in the first 3 years of life. It's usually triggered by viruses. There's no symptoms between colds. They're not atopic. And we think that it may be related to small airways at birth and maternal smoking. And episodes are usually mild, but they may be severe, and they likely outgrow. Whereas the persistent group starts before or after 3 years of life. There's multiple triggers, including viruses, allergies, irritants, and exercise. And the important part is they have symptoms between their colds and they're atopic, and they're less likely to outgrow. So this is just important to keep in mind when you're counseling families on, they'll always ask you in the preschool age, when will they outgrow this, or if they will. And the answer usually is that we don't know. But if they're atopic, then it may be that they'll be persistent. So I'd like to go back to the guidelines and talk about pharmacological and non-pharmacological treatment. And we'll start with what's not recommended, and I see this to varying degrees. So it's important to keep in mind that in the preschool group, daily leukotriene receptor antagonists, that's montelukast or singular, they're not recommended as monotherapy. Yes, you can use them as adjuvant, but the ICS is the mainstay of treatment. We also don't recommend stepping up a daily dose of ICS during a URTI. And yes, there has been some studies, I think in 2017, 2018 in New England Journal of Medicine about quadrupling and sometimes quintupling medication. It was not done in this age group, and it's not recommended and not supported by the literature. We also do not recommend in preschool group intermittent use of asthma controller medication at the onset of symptoms. And the preemptive high dose ICS at onset of upper respiratory tract should be reserved for asthma specialists only. So this just talks about the treatment. And so for mild intermittent symptoms, we would go to as needed salbutamol and adjuvant education. If they're having persistent symptoms or moderate severe exacerbations, so they classify those as ones that are requiring rescue oral steroid, we would definitely put those patients on a low dose ICS and as needed salbutamol with asthma education. Then I was talking about reassessment. They need to be reassessed, and if they're having an adequate response to therapy, then you're going to step up to a medium dose. And if they, again, an adequate response, then you consider a referral to an asthma specialist at that stage. By the way, we're also happy to see them at any point in time in this decision tree. Beclomethasone, which is QVAR, is low dose at 100 and medium at 200. Of note, this is per day, and beclomethasone is prescribed as BID dosing. So in that scenario, where you're starting them on a low dose, it would be 50 BID. Step up to medium would be 100. Ciclestinide or Ovesco is once daily dosing, and Flovent is, as you see there. Of note, the shaded areas are not approved for use in this age group. However, we're using them off-label all the time. And in fact, my go-to for that age group is typically QVAR for a few reasons. and most of them are anecdotal, but I do feel that they have a better response in that age group. Reliever therapy for preschool group will be salbutamol. It's always delivered with an MDI with a valve holding chamber and mask. We've really moved away from nebulizers. They're not shown to be superior to MDI, and they should be avoided. One of the silver linings of COVID is that we've stopped using them in the emergency department, which I think is great. Of course, if there's poor cooperation, distress, or hypoxia, you might consider using nebulized therapy at home or therapy in the emerge. And oral therapy is not recommended. I have another question. So when should short courses, less than 6 weeks of inhaled corticosteroid be used? Is it A, when a child has mild intermediate asthma with or without wheeze? B, when a child has viral triggered asthma symptoms? C, when a child is exposed to pets when visiting another home? Or D, the safety and efficacy of short intermediate courses have not been established, therefore should not be used? Or is it E, A, B, and C? Good. So for those of you who said D, you're correct. And I've been talking about that in my previous slides. The short courses have not been established and therefore should not be used. If they need to be, if you determine that they need to be on a dose of inhaled corticosteroid, that should be persistent and should be stepping down if they've been symptom-free. So the recommendations talk about the lowest ICS doses preferred first-line management once the diagnosis is confirmed and control has been achieved. And most children actually will achieve control on a low dose ICS. Intermittent use of asthma controller medication at the onset of symptoms has not been convincingly shown to reduce the number or severity of asthma exacerbations in preschoolers. And high doses of ICS should be reviewed by the regional asthma clinic or an asthma specialist. Let's talk about adjunct therapy in preschoolers. I think I've hammered this home, but inhaled steroids are more effective than leukotriene receptor antagonists. And by that I mean singular. It's not advocated that it should be monotherapy, and it's really second line only after an ICS is started in preschoolers. Long-acting beta agonists are not licensed or routinely used in the preschool population with asthma in Canada, although I have used it in my clinic for those who need step-up therapy. And in a combination product, I should say. And children who fail to achieve control on a medium dose of ICS should be referred. Let's talk briefly about prevention. I think I have some time left. There's no general recommendations with regard to avoiding pets, and parents who both have allergies to pets and ATP really should just avoid having them in the home anyways. There are some mixed reviews on breastfeeding. The bottom line is we wouldn't recommend against breastfeeding, and it should be recommended for all infants, as the benefits far outweigh any of the risks that are discussed. We should avoid exposure to environmental tobacco smoke during pregnancy in the first year of life, and that sounds like a no-brainer. But there is some evidence that it can lead to the transient wheezers, and we talked about that in the phenotype graph. Secondary prevention includes avoidance of known asthma triggers. Another silver lining of COVID-19 is that the normally circulating viruses are perhaps less at this time of year, and kids and children are perhaps presenting less with asthma, although I've definitely seen a few presentations more recently. Non-pharmacological management is actually the mainstay of asthma treatment, and it includes regular education at your asthma care visits. I'm seeing this less now in our clinic, but we typically, there are still patients who come in who use their preventer medication as the reliever and the reliever as their preventer. And so talking about that at every visit is important, even if you think they have a good grasp of things. Some of my adolescent patients often forget to use their spacers, so we tell them that the movies that they see on TV are wrong, and that they always need to have their spacer when they're using their inhalers. And we also talk and counsel about avoidance of irritants and environmental air allergens if the child is sensitized. I'll just touch briefly on asthma action plans, but to mention that I think they're very good in reinforcing good asthma management and control. And we also use them to write down the patient's medications so that they have knowledge of those if they ever should present to the emergency department. This is a sample and one that's provided through lung health. They talk about the green, the yellow, and the red. You know, green, your maintenance, you're doing okay. Yellow is time to increase your reliever medication, and the red zone is when you would seek medical attention. This chart is just to differentiate between preschoolers, those who are under 6, and older children and adults. So recommendations for step-up therapy are really none in the younger group, aside from giving more salbutamol. There are some other studies in older children that they increase the ICS or LABA at the start of an exacerbation, but those results have not been replicated in the younger age group, and it's not recommended. Just briefly touch again on the indications for referral to asthma specialists. If there's ever diagnostic uncertainty or suspicion of a comorbidity, we'd be happy to see those children. Or if they're not in control and they're having repeat exacerbations requiring oral rescue therapy or frequent hospitalizations. In this age group, importantly, in contrast to the older children, we talk about having more than 8 days a month despite being on a medium dose. That would not be in control, and that would require referral, or if they've ever had a PICU admission. Of note, I don't do allergy testing, but I'm happy to see the child and determine if they need a referral to a pediatric allergist, or if parents need reassurance or additional education, we'd also be happy to see them. So I just gonna double check the time. We have about 5 more minutes, and we can talk briefly about Billy. He is a made-up case, but it highlights some of the issues. So he comes to the clinic with cough and wheezing that lasted almost 3 weeks. There's a history of 2 emergency department visits requiring antibiotics, oral corticosteroids, and bronchodilators. He appears better with 30 minutes post-bronchodilator, and there's several colds in the last 18 months, most leading to prolonged episodes of coughing, wheezing, and dyspnea. No other medical problems, no symptoms between colds. Mother smoked 10 cigarettes per day during pregnancy. So what historical facts suggest that he has asthma? I'd just like you to think about this and answer in your own head. Is it recurrent wheezing, family history of COP, response to bronchodilators, or prenatal risk factors, or A, C, and D? So I would say A, C, and D. That if you remember from a previous slide, that prenatal or maternal smoking can play a role here. How would you rate his level of control? Is he well controlled, adequately controlled, well controlled with intermittent symptoms, or uncontrolled? And he's uncontrolled because he's having frequent symptoms in between presentations. And let's just look at that for a second. So in the preschool group, that includes more than 8 days per month with symptoms, or more than 8 days per month with use of salbutamol. Or we only tolerate more than 1 night per month awakening due to symptoms, which is different from the older age group. And we don't tolerate any exercise limitation or withdrawal from activities that they would normally enjoy. Moderate severe exacerbations, as I mentioned previously, require rescue oral corticosteroid, or those are the ones that require hospital admission. So following a diagnosis of asthma, what's the appropriate therapy? Is it you would initiate daily therapy with fluticasone BID and salbutamol PRN, 5-day course of 20 milligrams of prednisone. Oh gosh. Sorry, I jumped ahead. Is it montelukast or A and B? And you would start the. Trying to see if there's anything that I'm missing here. You would start fluticasone and salbutamol, and Of note, and this takes a while to wrap my head around, is it a therapeutic trial? So if you're not sure of the diagnosis, that would be a medium dose inhaled steroid. So more of the 200 micrograms of QVAR. But if you're treating and have a diagnosis in the preschool age group, the suggestion is to start a low dose, which I often found quite confusing. And my approach is, I think it's reasonable to just use a medium dose for all of my preschoolers, in my opinion. You might see differences there, but I think the risk of systemic or side effects is low in the medium group. And I think it's reasonable to try that even for when you have the diagnosis. So we would fill out an action plan, and then we would monitor him. So we need to look at control over a 3-month period, despite exposure to the child's typical and avoidable triggers. And you'd step down if he was doing well. And if his symptoms are minimal and he's on a low dose, then we can trial him off. So I'll just go over the key points of the presentation, and hopefully I covered all of these in a good, covered all of these adequately. Asthma can be diagnosed in children 1 to 5 years of age. So if people are saying that they can't do it because of spirometry or other reasons, then we're really moving away from that. The diagnosis requires documentation of airflow obstruction, reversibility, and no other diagnosis. Bronchiolitis, I mentioned briefly there, but it usually presents as the first episode of wheeze in children less than 1, and typically doesn't respond to salbutamol, although that's not always the case. If they're having multiple presentations for bronchiolitis, you may want to think more about the possibility of asthma. First-line therapy is low-dose ICS. I mentioned I usually do a medium dose. Step-up therapy includes increasing the dose or adding montelukast, which is a leukotriene receptor antagonist. If there's no response to therapy, we need to revisit the diagnosis, talk about adherence to medication, inhalation technique, and environmental triggers. And if poorly controlled despite all of this, then you would think about a referral to an asthma specialist. And finally, terms such as bronchospasm, reactive airways disease, or wheezy bronchitis and happy wheezers should be abandoned. We really are moving, the developers of the guidelines are moving towards a diagnosis of asthma, so they're identified as such, and then they get put on the treatment algorithm for asthma rather than something else entirely. Good. So I will leave it there. And then Lana had told me I can look on the question and answer to see if any questions are there. And it looks like we have lots of time. So if you'd like to put any questions into the box, I'll be happy to answer them for you. So Carolyn, thank you for the question. I'll just read it. So if a pediatric patient has 2 to 3 ER visits presenting with cough, but with final diagnosis of croup, would you consider seeing if there's underlying asthma with SABA or ICS trials? That's a great question. So let's talk about the preschool group, because that's typically your croup group as well. You know, I think it depends on where you're hearing the cough. If it's a chesty cough, then we'd be thinking more about obstructive symptoms. And then if you're hearing wheeze on auscultation, then you would definitely be thinking about asthma in that case. Of course, I've seen patients in that age group present with croup and also have a lower respiratory tract infection at the same time. So yes, I think it's reasonable to try SABA and to see if that would improve things. And then depending on how they're presented, depending on the level of their exacerbation, you know, their vital signs, if they're requiring oxygen, you may think about starting them on a medium dose of ICS at that stage with appropriate follow-up to see if their symptoms are improved. But I think this is also one where the history would come into play. So if they're presenting a one-time episode of croup, you have to ask if it's happened before. And if the cough tends to linger in the chest, they have cough at night or cough or wheeze with activity or emotion, then you'd be thinking more asthma. That's a good question. Hopefully I've answered it for you. And then you've asked a little off topic, but you had a case of a 9-year-old who had a methacholine performant and had a positive study at low dose. Respirologist saw the girl after testing, identified it could be a false positive. Can you comment on this? So in the methacholine tests are fairly specific, and everybody will be positive at some threshold, as you know. So it depends on what threshold that is. If it's an extremely low threshold, then I would be thinking that's more likely to be reactive and asthma in nature. And I'd say anything is possible. And in those kids, it might be worthwhile doing a trial of, I don't know your patient specifically, but a trial of medication to see if symptoms are better over time. So with that, I mean, a 50% reduction in oral corticosteroid use over the year, better control of nocturnal and daytime symptoms, and less use of salbutamol overall. And if that's the case, then I think you have a diagnosis. Hopefully that helps answer that. Hi, Jennifer. So back to school this year meant dealing with some unique challenges on top of the usual September spike. I would definitely agree. Interestingly, I'd seen not hard data, but some commentaries on asthma, and listening to some of the other presentations, I've learned that they may be in fact somewhat protected in that the regular ICS may downregulate receptors that are used to get the virus into the system. I think this is mostly theoretical at this stage, but I thought that was very interesting. And then we have this piece where children are less, let's say, symptomatic with COVID-19 and perhaps less severe presentation, and the actual etiology is not completely understood, but I found that very interesting. Well, it's a bit paradoxical, right? Because we think about children always having respiratory tract infections, throughout the fall and winter. So why would this be any different? But there may be some evidence that they're protected by having smaller airways and less receptors, which I found interesting.
Dr. Smith, sorry to interrupt. I actually have another question, COVID-related question that came to me through a different path. And if you don't mind, I'll just read it for you. During COVID, can you comment on how your practice has changed, and if it has, with regards to diagnosis? Are you going with more parental accounts of response to therapy or report of wheezing rather than documented improvement?
So I think, my discussion there about the risk of infection in asthma kind of goes into this. So I go by the parent report because they are probably having less presentations to healthcare providers when they're symptomatic. And with respect to COVID specifically, I'm not more aggressive with the diagnosis. But those patients who are coming to me during COVID with a known diagnosis of asthma, I'm more reluctant to wean them. And I think I'm not the only asthma specialist who is doing this. I was listening to a talk at the start of the COVID season, and that was definitely the recommendation, was to be very cautious in weaning these patients during COVID. And parents are usually on board with that when I tell them that I'd be very reluctant to wean. That said, I have actually weaned some, not completely off, but I've definitely weaned them with a good discussion of risks and benefits. Hopefully that answers that question to some extent.
Thank you.
Yeah. And so there's another question from John. Do we have to worry about any electrolyte imbalances in the heart due to too much ventolin use, or are children pretty resilient to side effects? And I think the short answer, John, is no. You definitely, if you're using continuous Ventolin, at which point they should be in an ICU setting, you can drive down the potassium, and at that point they would have a line and you would be trying to replace the potassium. But I haven't ever seen any cardiac side effects from electrolyte imbalances. I did have one patient when I was in my training at SickKids, I think it was an 8-year-old who was getting quite frequent Ventolin, and he went into SVT. That's not to say that that's a known risk factor, and this child may have been predisposed to SVT, we don't know. But I think those are rare. Philomena has a question I'll go over. So parents are always asking about long-term effects of ICS for children. Are some children more susceptible to adrenal suppression than others? Would you suggest some consideration for morning cortisol levels, or when would you suggest referral to an endocrinologist? What concerns or what should parents look out for suppression in these children? This is an excellent question with multiple parts. So I think are some children more susceptible? I'm not aware of any data that would suggest that one child's more susceptible than another, other than the dose of the total steroid burden that they're on. And there are some guidelines in Canada from Alexander Ahmed in Ottawa, which talk about our approach to these patients. So the current suggestion is to test for adrenal suppression or screen in those children who are on high dose of inhaled corticosteroids. And there could be some consideration to screen those on medium dose. At the moment, there's no agreed upon set of guidelines for adrenal suppression testing. However, it is reasonable to do an AM cortisol, as most people can arrange that in most labs. It has to be at the right time of day. And if there is a borderline or low result, then they should proceed to an ACTH stimulation test. Again, the experts don't fully agree on if that should be a low dose or physiological dose. But that can be done through an endocrinologist, or we do it in our asthma clinic as well. And so that's measuring the dynamic response of the hypothalamic pituitary adrenal axis. And then you've asked what concerns should parents look out for? So often these children with biochemical evidence of adrenal suppression are asymptomatic, but the importance of knowing if they're suppressed is that they could be at risk at times of illness or emergency surgery. And so for those children that we've identified with a positive ACTH stimulation test, we give a form and we give them a prescription for rescue steroid if they have illness, which is significant to cover their physiological steroid production. And to answer about when to refer, whenever you're worried is a good time to refer, or if they're on high dose, then perhaps they should be followed by a regional asthma clinic anyways, in which case we should be thinking about doing screening. Hopefully that answers your question. And then I see a question from Kristen. I'm just gonna check the time, we're good. A 4-year-old on Advair, which is a combination product, plus Cortef BID for immunosuppression in the yellow zone, despite Ventolin Q4, still symptomatic and given antibiotics, but not effective. Could additional prednisone be given as well? This child should definitely be followed in a pediatric asthma clinic, if not doing so already. Probably should have some input from the endocrinologist as they're on Cortef BID. If we're still symptomatic on Q4, I would actually go back to the history and see what mother is giving the salbutamol for. And because sometimes I get the story that they give it for a single cough. Other times they may not be giving it for obstructive symptoms at all, but it's important to elucidate that and then go over again the education piece to make sure they have good technique, they're using the spacers, and then could additional prednisone be given? Yes, but I think at that stage I would be talking to the endocrinologist and probably the tertiary respirologist as well. Good. Lana, I think that's it for the questions. I'll just wait another minute or two to see if there's any other ones.
I actually have another question for you too that I would like to ask.
Hey, no problem.
You know what I'm curious about, with you being a pediatrician, consultant pediatrician, you know, in the past, you know, things like happy wheezers and reactive airways were such common terms. So this CTS guidelines actually highlighted the fact that there is no such thing. Like I myself remember diagnosis of asthmatic component, you know, whatever that means. But so do you find that in the last 5 years since this guidelines came out, physicians are, you know, you know, I guess more reluctant to make a diagnosis of reactive airways? Do you think asthma is diagnosed more as a result of those changes?
Yeah, good question. I think we're moving in the right direction. When you look at some of the knowledge translation literature, it says that typically some guideline and recommendations to implementation is a period of about 10 years. We're about halfway through that. And I have seen, you know, some of the newer emerge docs and family docs have been applying the diagnosis of asthma. Sometimes they'll put in some qualifiers such as happy wheezers or viral triggered, which I think is fine because it speaks to the phenotype. But the importance is that they have the label. And a lot of discussion went into that guideline about so-called overdiagnosing. But they thought that the benefit is that they're labeled as asthma and they get treated as an asthma as opposed to something else, which would require additional investigations and unnecessary antibiotics. So yeah, I think things are changing.
Yeah, that's good. Great. Yeah. Thank you so much. So we have a thank you, which is very nice. And I want to thank everybody who was able to join. And some people have been joining us for all webinars, which is great. Now I would like to thank very much Dr. Smith for a wonderful presentation and very well presented, great cases, and you know, just very enjoyable. Thank you so much for joining us. And now just very quickly to remind everybody, next week, the same time at 12 o'clock on Wednesday, the 18th of November, Dr. Dina Radhakrishnan is going to be back. You remember she started our webinar series. So her previous topic was how do we manage asthma? And this time her topic will be is it time to change the way we manage asthma? And so this time, Dr. Radhakrishnan is going to focus on GINA 2019 guideline changes and recommendations and how they actually affect children and adolescents within the Canadian context. So please join us next week. And thank you everybody again. And thank you, Dr. Smith. And we'll see you next week.
Thank you.
Bye-bye.